Hello students, today I am going to talk about Cushing syndrome. Here I go with the definition of Cushing syndrome, how cortisol is produced, what are the effects of excess cortisol, what is the difference between Cushing syndrome and Cushing's disease, what is pseudo-Cushing syndrome, what are the screening tests, imaging studies and differential diagnosis of Cushing syndrome and its treatment. Those manifestations which you see because of excessive cortisol in the body, it is Cushing syndrome. About 68% cases are due to Cushing's disease. About 7% cases are due to ectopic tumors which are secreting excessive ACTH. About 25% cases are due to excessive autonomous secretion of cortisol by adrenal gland. Now, let's talk about how cortisol is produced. Hypothalamus, it secretes corticotropin releasing hormone. This hormone, it stimulates anterior pituitary gland. Then, anterior pituitary gland, it secretes adrenocorticotropic hormone which stimulates zona vasculata of adrenal cortex, which leads to production of cortisol. When there is excess of cortisol in the body, it increases the activity and sensitivity of sympathetic nervous system. That leads to stimulation and upregulation of alpha-1 and beta-1 receptors. So, there is vasoconstriction and increased myocardial activity which causes tachycardia and secondary hypertension. This hypertension, it is refractory to many antihypertensive drugs. There is also inhibition of neutrophilic margination along the walls of blood vessels. So there is decreased diapedesis. There is also inhibition of T cell proliferation and antibody formation. All this together, it causes decreased immunity. So there is increased risk for infections, especially fungal infections. Another effect of raised cortisol in the body is it stimulates gluconeogenesis and glycogenolysis, but there is inhibition of insulin production. All these together causes raised glucose levels in the body. This leads to increased risk for diabetes mellitus. This is diabetogenic effect of excess cortisol. A patient with Cushing syndrome appears with moon face, buffalo hump, abdominal obesity because of central fat redistribution and thin extremities because of lipolysis at extremities. Excess cortisol, it causes increased protein breakdown that results in proximal muscle atrophy, and there is also impaired collagen synthesis that results in osteopenia that causes increased risk for fractures, and the skin appears thin which is manifested as striae over abdomen, ecchymosis and slow wound healing. Impaired gonadotropin releasing hormone production due to excess cortisol results in decreased FSH and LH production. That may be a cause for decreased libido and amenorrhea. Any anterior pituitary tumor which increases ACTH production, thereby increasing cortisol levels in the body, is Cushing's disease. A pituitary tumor, in addition to raised ACTH levels, it may also increase melanocyte stimulating hormone production that is manifested as hyperpigmentation. Raised ACTH levels may also increase androgen levels in the body that results in acne and hirsutism. Ectopic ACTH production is another cause for Cushing's disease. The most common causes are small cell carcinoma of lung, some pancreatic tumors, renal cell carcinoma. The excess cortisol in these cases is unable to inhibit ACTH production through feedback mechanism. In case of Cushing syndrome, which arises due to an adrenal tumor or iatrogenic, the raised cortisol levels is able to decrease ACTH production through feedback mechanism. As I said, there is impaired diapedesis in this patient, so the patient appears with relative granulocytosis and lymphopenia. A person who is infected with HIV and is on retroviral therapy may develop symptoms like Cushing syndrome. This is pseudo-Cushing syndrome. Out of the 3 screening tests, 2 should be positive to say it a Cushing syndrome. The first one is low-dose dexamethasone test. In this test, when dexamethasone is given, in normal people, it should decrease the production of ACTH. So, in these people, we should find low cortisol levels. Whereas in Cushing patients, the cortisol levels still remains high. The second and third screening tests are 24-hour urinary free cortisol levels and late night salivary cortisol levels. If you find the cortisol levels are higher than the normal, it indicates Cushing's. But with these screening tests, we cannot say whether it is Cushing syndrome or Cushing's disease. To differentiate between these two, you need to check for ACTH levels. ACTH levels are increased in Cushing's disease and they are decreased in Cushing syndrome. The causes of Cushing's disease is pituitary tumor or ectopic ACTH producing tumors. The causes for Cushing syndrome is adrenal tumors or iatrogenic cause. The normal levels of cortisol in saliva in late night is about 150 nanograms per deciliter or less. In late night salivary cortisol determination test, the sample is collected around 10 to 11 pm. If the cortisol levels are found more than 250 nanograms per deciliter, it is considered abnormal. In overnight dexamethasone suppression test, dexamethasone 1 mg is given orally at 11 pm and the sample is collected at 8 am. If the cortisol levels are found less than 1.8 micrograms per deciliter, the chances of Cushing syndrome to be less. High-dose dexamethasone suppression test is used to know whether Cushing's disease is of pituitary origin or ectopic origin. In this test, 8 mg dexamethasone is given. If the cortisol level falls, it indicates the problem is in pituitary. If the cortisol level still remains high, it indicates there is ectopic ACTH production. Alternative test to high-dose dexamethasone suppression test is CRS stimulation test. In this test, corticotropin-releasing hormone injection is given. If the cortisol level rises further, it indicates presence of pituitary tumor. If the rise of cortisol levels are not to much extent, it indicates ectopic ACTH producing tumors. This happens because a pituitary tumor will have more number of receptors for CRH. Now, coming to imaging studies, if you suspect adrenal tumors, go for adrenal CT or MRI. If you suspect pituitary tumors, go for pituitary MRI. If you suspect ectopic ACTH producing tumors, go for CT chest or abdomen and pelvis. The clinical features or biochemical changes of Cushing syndrome is seen in many cases, like in chronic alcoholic patients, pregnant women, critically ill patients, depressed patients, and in anorexia nervosa. Now, coming to the treatment part, a patient with Cushing syndrome should be treated for all cortisol-dependent comorbidities, like if the patient has hypertension, it should be treated. If the patient has hyperglycemia, it should be treated. If the patient has pituitary tumor, go for transpenial resection. For adrenal tumor, ketoconazole or adrenalectomy. For ectopic ACTH producing tumors, chemoradiation, surgical removal or ketoconazole. If the cause is iatrogenic, taper the steroid dose. PDF link of this lecture is provided in description.